Welcome to the Empower Podcast, the show where we discuss big ideas with leaders and change makers as we work to create a Mississippi where everyone can rise. This is Grant Callen. Thank you for joining us. Healthcare is one of the most complicated and consequential policy areas in Mississippi. From the future of rural hospitals to debates over certificate of need laws, scope of practice rules, and the opioid settlement, for good or ill, the decisions made in Jackson often shape whether families across our state can access quality care close to home and how they pay for it. Today's guest is State Representative Sam Creekmore, who represents District 14 in Northeast Mississippi and serves as the chairman of the House Public Health and Human Services Committee. In that role, he has been at the center of some of the legislature's most significant health policy debates. Representative Creekmore is a landscape architect. He's a graduate of Mississippi State University and lives with his wife, Warner, in New Albany, Mississippi. Representative Sam Creekmore, welcome to the Empower Podcast.
Well, it's good to finally be here. Thank you for inviting me.
Well, I have been looking forward to this, and thank you for coming in. So I thought we could either start with Bobby Gentry or Union County Barbecue. What do you think?
That's one of the great things about being in the legislatures. You can come up with ideas that can sometimes be fun and entertaining and honor certain people. So I love Bobby Gentry.
Yeah, so you had these are two resolutions. We'll get to the serious stuff. You had two resolutions, I think. I think they were both resolutions.
Well, actually, I've done a resolution for Bobby Gentry.
Okay.
And this time I did a bill declaring June 3rd as Bobby Gentry Day in Mississippi. So, she's one of the great Mississippians that's really impacted the world. And singer-songwriter, owner of an NBA team. Just a Renaissance-type person who's still alive today, and I just would like to honor her in Mississippi. June 3rd is the first line of Ode to Billy Joe.
Oh, that's right.
It was the 3rd of June.
Which was her most famous song.
That's right, worldwide.
Yeah.
And it also really put the Tallahatchie River on the world map.
Yeah.
So I did a bill a few years ago creating the Tallahatchie River Authority. And I didn't think much about it. Regionally, it's an important river to North Mississippi, but it was picked up. That story about the bill was picked up around the world. The Miami Herald wrote about it. L.A. Times wrote about this bill, and I give Bobby Gentry the credit for that because nobody else really knows. The civil rights movement was the Tallahatchie River's historical in that aspect, and then Bobby Gentry's song. So it's pretty neat.
Okay, so you have been in the legislature 7 years.
That's right.
And as I was thinking through, the number of bills that you carry now for being in your second term, it's pretty remarkable, the level of leadership that you have in the legislature in such a short time frame. I'm curious what led you to lead on healthcare policy.
Well, I didn't choose healthcare. It really chose me, and I think the Lord led this intersection between me and healthcare. And it really started about 4 years ago in Judd B. And we did a hearing. Nick Bain was chair of Judd B. And we did a hearing on the drug issues. And we did a hearing on mental health and why people were ending up in jail. But I think the drug issue was first. And that hearing, I remember telling Warner, my wife, said, I really don't want to go to this hearing. It was during the summer. I was busy, and I knew the subject matter was going to be very difficult. There were parents who had lost children, and it's like I just don't want to go. Mm-hmm. But I did. It's my duty. And at the end of the hearing, it was very difficult, very sad. At the end of the hearing, Nick Bain, and this is such a legislative way of doing things, he makes the announcement, all right, we're gonna form a subcommittee in Judd B, and Creekmore's going to head it up. I was getting ready to go home. I had no idea this was coming, and so that really started my journey into healthcare and it started with the mental health part and addiction space, and then it was in Philip Gunn steps down, in comes Jason White, the new speaker, and I didn't ask for chair of public health, and he just made that announcement. I'm going to chair public health. So here I am. And, it's somewhat fitting. My father's a general practice physician, uncle that was a ear, nose, and throat, daughter-in-law that's in med school now. So I've grew up, with 3 o'clock phone calls to wake my dad up, and you got to go to the emergency room. I've just been in it my whole life.
Well, we're going to go through some particular issues that you've worked on this year and in recent years, but I'm, I guess, curious sort of what has been the most rewarding and also challenging about that particular issue of leading healthcare policy for the House?
Well, there's several things, but in Mississippi we got a lot to work with. We are the most unhealthy state. We're the most obese state. We have high infant mortality. So there's a lot of issues, very difficult issues that we need to address. And I really credit Speaker White's leadership, and I know you've had him on, but his very first speech he gave as speaker, he talked about chasing lines, and meaning we're gonna go after the toughest issues in Mississippi. We're gonna put them on the table, and we're gonna try to solve them. And so I've kind of taken that mantra and ran with it. So that's rewarding. The opioid settlement, that's very serious to me. I haven't really done this long enough to see. I've seen trending results where things are going in the right direction, but not necessarily everything fulfilled like I want it to be at some point. It just takes time. There's a ibogaine was very, very important to me, that we look at this and try to get something done, and we can get into that later if you desire. So that's been very rewarding and really been a spiritual journey for me. Then for mortality, there's so many things that we need to address in that. The certificate of need, to get that across the finish line, which we're on our second bill, hopefully today Hobbs can get it out of the Senate. And to have that done, it'll be the first time we've had significant CON in the history of the state of Mississippi. And, that innovation, or that helps be the catalyst for innovation in healthcare.
Yeah.
CON thwarts innovation.
Yeah.
And so just things like that. We got a lot to work with. I got a lot to do.
Well, okay, we're going to get to CON next, but how do you think, from a governing philosophy, how do you approach healthcare? Because healthcare seems to me one of those issues that makes it really challenging to navigate, because unlike most business relationships where you have the business and you have a customer and the customer pays the bills for the product or service, in healthcare you often have 3 payers. I mean, you have the patient paying something, often you have health insurance, and you have the government. And obviously not every patient has all 3. Many don't have all 3. But if you look at hospitals and you look at clinics, they certainly have all 3 as payers. So how do you, maybe just big picture, how do you think about healthcare policy when you have 3 different payers?
Well, that's interesting. And then you throw into the fact that hospitals cannot turn people away.
Sure.
By federal statute, they have to see you. And whether you can pay or you have the other 3 mechanisms to pay or not, they're going to treat you.
So what other company, if you walked into Kroger and said, you have to give me food and my months of grocery bills, whether I pay or not, that affects their revenue plan and their business model, right. Big time.
Yeah, I'm hungry, so give me something to eat.
Yeah.
I can't pay. So you got that dynamic too. But you look at it, one, you have the hospitals sector over here where they can't turn somebody away. They I think many times deserve some assistance from the government, who's the very government that's requiring them to take all patients. And then, I'm looking at and having the health department study. There are private clinics, single specialty surgery centers, multi-specialty, that can turn people away. They don't see uncompensated care. So maybe there's an increase in licensing fee to help offset some of the hospital's expenses. But it's a very complex, and you want to be fair in it all. So I look at hospitals a different way than necessarily a clinic or scope of practice. And then in Mississippi, the access to care is such an important aspect. We're here in Jackson. We got great access. I was in the Delta this weekend, and access wasn't so great. So, you got to find ways to keep Greenwood, Indianola, and some of these rural hospitals open and functioning. And if that is someone having to pay a higher licensing fee in Jackson to take care of uncompensated care in some of these rural areas, maybe that's something we do. But, I just look at that a little different than I look at my business or your business.
Certificate of need. What is it? One of the first bills that passed this year was House Bill 3, which was a certificate of need reform. And as you mentioned, y'all are working on another one. Maybe just give an overview. What is a certificate of need, and why was it created?
Yeah, it was started in New York State in the late or early 70s, maybe late 60s, and then was picked up by the federal government in the 70s, and they initiated it throughout the country. And what it does is in healthcare, you have to apply for a certificate of need to perform a certain service in a certain area, or to build a hospital in a certain area. There has to be that need for it. And if you ever get it, then you're protected. No one else or your other people are limited and cannot compete with you. And, it's good in some ways, and in some ways it's not so good, because competition, I believe, is good and helps keep costs down, and helps keep people on the top of their game, and helps, to me, spawn innovation. Where certificate of need kind of thwarts those. You don't have competition. You're not looking for innovation because you're protected in your business. And so in Mississippi, there have been states since that federal mandate on CON throughout the country. There have been states that have repealed it. Mississippi's never changed. We may have tweaked here and there. So House Bill 3 this year was an important step. We took some low-hanging fruit. We upped the capital expenditures, was really the biggest thing. We doubled it.
So it had a higher threshold that you would need to get. You could make improvements without getting a certificate of need. Is that right?
Yeah, it's kind of the silliest thing. And to buy let's say an MRI piece of equipment that costs $4 million, a hospital or a clinic had to apply for a certificate of need. They had to pay money, attorneys, to get this application. Has to be reviewed by the Department of Health, and then there's a chance they were denied to provide a service or to buy a piece of equipment.
To grow their business.
Yeah, to grow a business. So we doubled those thresholds in House Bill 3, which wasn't enough. But we saw this is something we can start, be the catalyst to kind of get the ball rolling on CON reform. So the plan was to come with this next bill, which is what we have now, to take that even further. And the appetite has been there in the House and in the Senate to get these reforms through.
I think that first bill was actually something y'all passed last year that the governor vetoed.
It was.
And he kind of outlined in his veto message the piece of it.
He did, yeah.
And then y'all took that piece out and came back?
We took it out, and it was a lawsuit that was involved the state, and it probably really didn't need to be in there. We were just trying to clean that up. But it also, in House Bill 3, it did limit UMMC's ability to use their teacher exemption of CON and apply it outside their main campus. They have properties and clinics and hospitals all over the state, and that CON exemption applied to them, so they didn't have to follow the same rules as the hospital next door. So we actually required them to apply to CONs like everybody else outside their main campus. So that's what House Bill 3 did.
Is it a fair summary to say supporters of CON say that when a big part of healthcare policy is government funded, there's a government interest in sort of providing some protection so that a hospital can make an investment without having to be fearful that somebody next door is going to, create an immediate competitor where they've made an investment and drive and basically affect their ability to pay off that investment.
Yeah.
That's kind of the argument that supporters would say. Opponents would say, well, the free market always drives down prices.
Yeah.
And if we just got rid of CON entirely, a freer market system would allow more consumer choice and lower cost. Is that kind of a good assessment of the two sides?
It's a good assessment. And the idea was it would keep healthcare costs down and like you mentioned, protect the hospitals. But we have the lowest healthcare costs in the country in Mississippi. So we're achieving that. And we've kind of outgrown CON. It's kind of matured to the point we're not necessarily building new hospitals right now. So that the way I look at it is CON had its place, and then we've kind of aged out of it now. So we're slowly, and to be honest with you, I don't think a full repeal would be fair anyway right now. I think businesses need to plan and have time to change their business model. That there will be competition coming soon. Let's get our ducks in a row, because they see that the legislature is trending toward removing CON in healthcare.
So I want to go back to an issue you mentioned that was kind of your entrance into healthcare policy, and that is the way that we were using our jails to, in a lot of cases, house folks with mental health issues. Mm-hmm. Have we made progress on that issue?
We have. We've made. And that's one of the most rewarding things. Like you mentioned at the very beginning, that's we've cut that in half now. We're not there.
Wow.
But we've cut it in half with the policy that we've changed. And one of the biggest changes was, to have someone committed, there's a process you go through, and the evaluation process was the third step. It was a simple move, but we moved it to the very first. So. If you want someone committed, they're evaluated right away. And then so many times in mental health, commitment's not the best thing. You can get help without ever going to a facility where you're housed and put in a bed and monitored. Most of the time, it's called diversion, and it can be diverted to CMHC where they can help you, and then you go home, or you can call at 988 and get some help over the phone. So many times we really emphasize that diversion and giving people and exposing the options for mental health patients. But sometimes they have to be committed. And then there was also a big push for facilities, but we've really found out that we probably have plenty of beds for people to be housed and treated, but we weren't communicating. We didn't have a bed registry.
And you're not talking about in jails. You're talking about in mental health.
Right. A mental health. Someone's picked up for mental health by the police. Many times they're first responders. They don't know what to do, and they take them to the jail. Then they come be evaluated by the community mental health center. So we've tried to get this evaluation to be the most important piece and the front piece. But we also want we passed another bill, and I'm kind of going around the world with this, but we needed to educate our first responders. So there's a course called Mental Health First Aid, and it's really for law enforcement or for anyone to be able to recognize a mental health situation and then the options to deal with it and how to de-escalate. So we required all law enforcement to take mental health first aid and throughout the state of Mississippi. And we also a crisis intervention team or a crisis intervention training officer to be at each station, just one. And so this has really played a major role in educating law enforcement and first responders on how to handle it, what their options are. And then we created this bed registry, which we're going to take that to another level, hopefully, after this session, where community mental health centers, hospitals, emergency rooms can get on this bed registry and see, well, if I'm in Tupelo and I don't have any beds available in my area, but Corinth does, and they can see in real time, and they can send that person to Corinth to be treated where there is vacancy. So just really common sense solutions, communicating and educating has been very rewarding, and we've moved the needle in mental health space with that.
So it's said often that, we expect teachers to do all kinds of things that beyond simply what they're intended to do. And this sounds a lot like it's like law enforcement. We're expecting law enforcement to do a lot of things beyond what they were ever trained and intended to do.
That is so true. And unfortunately or fortunately, that's who you call. If there's someone misbehaving in mental health, often leads to misbehavior or breaking the law, then the first responder, and I'm including firemen in this too,
sure.
and ambulance, and that they're all involved. But you're right, and so this first mental health first aid is not necessarily for them to treat, but it's for their protection as well, and to recognize how to handle and de-escalate the situation. It does put a lot on them, and I apologize for that, but they're first responders and called first responders for a reason.
Yeah, and it sounds like it's giving them a next step beyond just throwing them in jail.
That's
when
right.
A jail is not going to be the best place if their only crime, which is having a mental health episode.
That's right.
So let's talk about ibogaine.
Yeah.
People have probably seen that word in the headlines. What is it? What is the legislature looking at related to ibogaine?
And I'm going to give you a little backstory. It was during session last year, and I was working on the ibogaine bill for the settlement, creating the ibogaine advisory council and all that. It was a Saturday, and my phone dinged, as it sometimes does, alerting me of a podcast like it does for you. And it was Joe Rogan, and it was Governor Rick Perry and a man named Brian Hubbard. And so I'll just turn it on and just see what this is about. I always liked Rick Perry, and former governor of Texas.
Sure.
And so it began. They talking about this drug, not new, but it's a drug from a plant, the iboga plant found in West Africa. And this compound from the root of the iboga plant is used in substance use disorders and in PTSD. Well, I'm sitting here working on this opioid settlement bill, and so I was like, and it just captured me. And it just, again, I think it was the Lord intersecting me and ibogaine. It's a psychedelic. And they talked about, and I've done so much research since. After one use of ibogaine, in which is done in a hospital or clinical setting with a doctor and a nurse, and you have to do all this qualification just to see if you can take it. You have to be healthy enough. But after one application, 80 to 90% of people suffering from PTSD are recovered. They're made whole. I mean, it was just staggering numbers.
Wow.
People who've been through addiction, it was 70 to 80% people who have been on opioid, the withdrawal symptoms are gone one time, one treatment. And so I was like, I reached out to Brian Hubbard through an email. He immediately contacted me, and he invited me to study ibogaine in the first ever ibogaine conference in America. And so Dr. Tom Recor, Department of Mental Health, who I respect greatly and is brilliant, I called him and said, would you go with me? And he had heard of ibogaine before. I'd never even heard of it. And so I knew he could take the complicated and from that we're going to learn at this conference and be able to explain it to me. And so he and I both went, and it was just phenomenal, the studies and the education we learned. And Dr. Creekmore became one of the leaders at this conference. He's just a wealth of talent that we have in Mississippi. So I just had the idea, let's use some of the opioid settlement money. The legislature has $54 million at its disposal, and let's join Texas. Texas passed an ibogaine bill for FDA trials in the state of Texas, and they left the bill where other states could join them. They put $50 million into this, and so I said, well, we'll join Texas. We'll put $5 million of our 54 that's available for the legislature to use for FDA trials, and the reason for FDA trials, that is the quickest way we can get Mississippians treated in Mississippi. They can go through the trial. Granted, some will be taking a placebo, but so hopefully we'll partner with Texas. We'll get a drug. They'll partner with a pharmaceutical who will also put up the matching fund. So that's $10 million, and perhaps a UMMC will join in this effort. A hospital will have to join. It doesn't have to be UMMC, but they seem to be the likely candidate. And we can start treating Mississippians for addiction, for PTSD, for traumatic brain injury. And I think it could be a moonshot of a chance for Mississippi, and really a chance for us to lead the country. You know, in this journey, and yes, I've interviewed and had hearings, and we've had Mississippians, veterans, true war heroes, just who've gone to Mexico. They've suffered from post-traumatic stress disorder. We're on the verge of suicide, losing their family, can't keep a job, who have gone to Mexico to get this treatment, have come back and now are leading productive lives in Mississippi. And I'm talking about Mississippians, people who live. There's a guy that lives 5 miles from here that's done this. I mean, there's a nurse. They went through all kind of traumatic events as she worked in the emergency rooms, and she suffered from PTSD, and she's been through counseling, and could never get put back on the right path. She did it. And so there's countless stories of local people who've received this treatment, have been made whole. So to me, after the mental health, after the studying the drug addiction, I think it would be, I'm not doing my job if we don't consider this. And here we have this chance to use money from the opioid settlement that people died for, to give people a chance to bring something new and innovative, and a new option for people who really are at the end of their rope. And I'll say this, the gold standard in America for substance disorder recovery is about 30%. Terrible.
Yeah.
And why not look at something that's seems to be doing an incredible, by far, making people whole again and making people well again, by far exceeding our gold standard in America. So it's been a great journey. It's been a spiritual journey for me, and just when somebody goes through recovery and they come out on the other end, they are productive. They're giving. They're great citizens for this state, and they want to help other people. And so this has been very rewarding. And if we can get more people to that other side, they become better people in Mississippi, and we need them. We need to help people in Mississippi.
Is there a reason with such promising stories that pharmaceutical companies haven't stepped up to invest or bring this to market?
Great question. Well, number one, it's a Schedule I drug. To be Schedule I, it has to be very addictive and have no medicinal value. To me, this doesn't qualify for either one. It's not addictive, and it has great
medicinal value.
But it kind of got lumped in the 70s with the Nixon administration. They classified several drugs especially in psychedelics, as bad, and just put it all in Schedule 1 without a whole lot of study involved. So it's kind of been there. So you got that Schedule 1 aspect of it, which is not appealing for pharmaceuticals. But pharmaceuticals, as I mentioned earlier, our gold standard being 30% successful in the addiction space, they're making a lot of money off of our current drugs that we had to fight, and it never solves the problem. So they can keep selling. You keep taking the drug to stay off drugs.
Yeah.
This is you do one time, hopefully. Some people go back for a second dose. So that you got those two things working against you. So that's my reasoning for why pharmaceuticals have kind of stayed away.
And I guess that's the reason your legislation would not make this drug. I mean, you're not just trying to make it legal. You're trying to invest in it so that the clinical trials. I mean, I guess part of the path to become legal are the clinical trials.
Yes.
So the state would invest $5 million to get it through the process so that ultimately, as you put it, some would get access to it immediately in the clinical trials, but the ultimate goal is that it'd be FDA approved.
That's right.
And then it'd be much more widely accessible.
That's right. And it's unique, and I think applicable to this podcast. When Mississippi gets involved with something like this that's innovative and is on the cutting edge as far as America is concerned, other states notice. When at this conference, and there was Arizona and New York and all these, and then there was we were there from Mississippi, and they, what are y'all doing here? But it's really picked up, when especially as far as this bill, which is right at the finish line now, when the whole country's watching, and it's been pretty unique, this experience, and how people watch what Mississippi does.
We're not a state that's known for taking the first step or being particularly innovative in policy. A lot of times we're one of the last states to get involved. So.
That's right. And this ibogaine for America, this is a national organization that formed just this past year. They were like, you don't know how important it is for the rest of the country to see y'all get involved. Yeah. And so it's been neat. And I truly believe we can help. We can help. It's the other thing, to have the support of the veterans, the very people who fought and protect us have to leave our country to get help sometimes, and to be able to offer that here and let them stay in America and in Mississippi. I don't know. It's rewarding, and it's humbling, and it's been a great journey, and I hope we can see it through.
Well, so you say it's at the finish line. House has passed the bill. Has the Senate passed it?
The Senate passed it.
Okay.
And I had an amendment on the Senate side just to clean up some duplicative language that Texas had, that if they're applying for the trial, then we don't have to apply. So save us some money. They passed that amendment, so I have to concur on the House side. So when it comes back to me, I'll concur, and then it's on its way to the governor.
As we've done a lot of work in the criminal justice reform space, I've become convinced prison is not the best place for somebody whose only crime is a substance abuse, addiction to a substance they weren't supposed to have, or possession of something they weren't supposed to have. And sure, if they commit another crime, but that's where I'm a big fan of drug courts, big fan of diversion programs, and what I find is that you see if they go to prison, they come out worse than they went in, and they don't dry out in prison because there are more drugs in prison than out sometimes. Yeah. So what are the solutions there?
Well, that's a tough one. I don't know that I have the solutions. I do, and I love Becky Curry to death, and she's working in that space with some remarkable ideas, just having trouble getting traction. But one of the most successful things, but they're not created equally throughout our state, are drug courts. Yeah. And in my area, drug courts is fantastic. It's phenomenal, and it keeps people out of prison and requires them to be productive. You have to get a job. You have to do drug testing. You have to pay your fine, and that keeps you out of jail. And so it's working extremely well. But as I've learned, and this came early on when I was talking about the Judd B stories, the drug courts, when I say they're not created equal across our state, it's a voluntary position for a judge. They can do it or not do it. And what you have is the ones that are passionate and care about these people and try to get them help. These judges are successful, and they're doing it with limited funds, and they're not getting paid. So if there was a way we can incentivize or these judges and try to bolster some of these drug courts that are not doing well, they're not doing well because they're not being used, and there's not much follow up. If we can somehow get that on a level playing field throughout the state with our drug courts, I think that is a major look. And my kids now they're young adults now, but growing up through the formative years, I mean, I just preached about how one mistake with an illegal drug or somebody just gives you, here, take this. You don't know where that came from. They're pill presses in somebody's garage that they could have made something, and
potency is all over the place.
A grain the size of a grain of salt of fentanyl will kill you. Yep. And so, but there are kids that just made a mistake or just was trying to fit in. Not that made it right, but they end up in jail and then their whole lives change.
Yeah,
or
dead, or overdose.
So just to give options.
Yeah,
options are good, and let's create a path to being productive citizens in Mississippi.
Yeah, and I am firmly convinced our prisons are necessary, our jails are necessary because there are dangerous people that need to be off the streets. But someone with a substance abuse issue isn't necessarily dangerous. And we've got to be able to distinguish and give judges the tools for when they come across somebody who's not a danger to society, a tool to do something else with.
Absolutely. And as we talked about earlier, and I think it's important to understand that when someone comes out the other side made whole and have beat the addiction, they're a great person to have in your community.
Yeah.
And they're productive, and they care about other people. And as you mentioned, they're humbled but just become great tax-paying citizens that make others better, for the most part.
Yeah. Well, we've hit on a lot of healthcare policies. Are there other healthcare issues you're working on you want to discuss, or what other topics are you following this session? Are you interested in?
I had 150 bills in my committee, and I think I authored 51 of them. And the speaker made the comment, you're doing too many bills. And Delbert told me the same thing last year. Quit sending us bills. Well, there's so many, and we have so much to do. There's testing for the genetic testing and biomarkers. Those are important bills that we passed this year that give people, give doctors the opportunity to let you know this could be an issue for you, or be looking out for, you could have some type of cancer on the horizon that and live your life this way, or start taking these precautions. And so we were able to get biomarkers passed last year, genetic testing the year before. But these are just things. The other thing is that technology and medicine's changing so fast that, and it's a good thing we meet once a year, because we need to do that in Mississippi to keep up with the technology that we have. Proton therapy is another one. It's a form of radiation that's specific to a certain organ, and so it can be less harmful to you if you have a proton therapy radiation shot or procedure. But our CON laws are so antiquated that it's proton therapy, although unique and different and specific to a certain area, is still radiation. So our CON laws from the 80s say, well, we don't need proton therapy because we have enough radiation treatment in Mississippi. No, we don't. We don't because we can't allow proton therapy. So that's a bill I'm working on right now to get that where we can have. This is a $50 million investment for proton therapy. Right now, Mississippians have to travel to Houston, Texas, or Little Rock to receive this treatment, and we have someone that wants to do it right here in Mississippi, but they can't get the CON law. So that's another one that I'm working on. And I don't know if you were going to go into this, but scope of practice.
Yeah.
And, I've been on both sides of this issue. My father's a physician. So prior to getting in the legislature, and even for the first 4 years, I was not for really changing
for
any
expanding scope for nurse practitioners.
Correct.
Okay.
And so, but, we hear so much about healthcare availability, access to care, lack of healthcare workers in all areas, but especially in our rural areas. And I saw this scope of practice maybe being a way, if we expand scope, maybe it's just in certain areas, but would increase our access to care. So that's something, I didn't take any scope of practice up this year with the intent of studying it with the help of the Department of Health, with the help of the Mississippi Medical Association, and with the help of the nurse practitioners. And let's all come to the table, chase that line, and see if we can improve access to care and health care in Mississippi, especially in our rural areas.
I mean, that's one of those areas that, candidly, we have supported expanded scope of practice. We're not trying to turn nurse practitioners into doctors. They're not. But we want nurse pracs to be able to operate to the extent of their training. And, often the argument that I've heard is, well, we want excellent physician care for everybody. Yeah. And, of course we do. But there are places in the state where no care is provided because they're rural, and we can't get physicians to go. And if you could get nurse pracs to be able to go and offer care up to their level of training, to me that's just a no-brainer. And they're doing this in other states.
That's right, and the sky hadn't fallen.
And
so the term they like to use is physician-led healthcare, and I think you can still have physician-led healthcare and allow expanded scope for nurse practitioners. So that's kind of my approach to it, and I think we should attack it like we've done the CON. Let's start with some of the areas that make sense. It's low-hanging fruit. Let's start doing that, expand that scope. Maybe it's with the CRNAs who are doing 78% of the anesthesia procedures in the state, and an anesthesiologist oversees them, but they're doing the work. Maybe we expand their care. The other point I want to make to this, and what has kind of changed my mindset on this, having grown up as a father who was a physician, he delivered babies. He, as a general practice physician, there was nothing he really didn't do. Gave shots, and pretty much everything he did, and he didn't have a nurse practitioner working for him. He was there. And so today, when I go visit his clinics, there are 5 nurse practitioners doing a lot of the procedures, and he no longer obviously doesn't deliver babies or OBGYNs. So healthcare has matured, has advanced over time. General practice physicians may not be expected, or not in New Albany anyway, but in probably rural areas they probably still are, but to do so much and have so much fast, they rely now on nurse practitioners to do it. So let's open that up and give them a little more, in my opinion. Something we can hopefully all agree to, and give them a little more expanded scope.
Yeah. Well, let me ask you about, you mentioned you've had a lot of bills. You've also had a lot of success working with the Senate to get things done. And I think about Jeff Pender had a column a couple weeks ago where maybe it was a week ago, asking the question, is the relationship between the House and the Senate the worst he's ever seen? There's a lot of folks saying right now the breakdown and the animosity and the frustration between House and Senate is at an all-time high. I guess my question is, one, do you see that? Do you think it's at an all-time high? And two, how have you worked to navigate that and still get stuff done?
That's a great question. As I walk the hallways and I try to negotiate my bills or other bills, I don't feel that, I don't have that sense of us against them, or we're not on the same page. But then, it seems to be more at an upper level that there's a disconnect. And I really can't put my finger on it as to why. I believe the lieutenant governor is I like him greatly, and I think he's a very smart, conservative person. And I know Jason White is our Speaker of the House. So I just don't know where that disconnect is. But I think it's more at that level than at my level, which, I'm a Republican. I'm conservative by nature. Hob Bryan on the other side is public health chair, is a Democrat. Maybe a little more liberal
A bit.
than me, but prior to sessions or even during the summer, this is what I'm working on. I try to keep him informed, and he does me, and let's work on, for instance, CON. Mm-hmm. This is important to me, not so important to him, but it has become important to him. And we're probably 60% of what I had originally proposed in CON, but I'm willing to work with Hob to get him to move. I'll take my 60% as a win to get some CON reform, and maybe next year we'll do a little more. Same thing with scope. So, I get along with the Senate, and I get along with Hob, and I try to work. It's not an all or nothing with me, and that's really how the legislature's set up. I'm a sports guy, and been a teammate, had teammates, and to me that's what we are as a team, and we have to work together. We have the same goal at the end, is to win. How we get there is not always everybody agrees, but we need to come up with a game plan. If it's income tax, whether it's school choice, whether it's health care, if I can get 60% or more, that's a win. And then let's keep
100%.
going. We're never done.
That's right.
We meet every year for a reason.
Yep.
The world's constantly changing. And so let's take what we can get and keep going.
Where are you going? Are there things that you haven't tackled yet, or things you would like to see your committee tackle in the coming years that you think are important and necessary that you want to work on?
The infant mortality. I've looked back at our history. We've always been the worst in infant mortality. And there are many ideas, and I'm convinced that it's money, that the poor areas, the poverty where the poverty level is the highest is where we had the most infant mortality, in my opinion. And I'm also convinced that it's mothers. They don't choose. They want what's best for the child. I believe 90% of them care. And if we can find a way, and you and I are probably going to differ in this, but the most effective program I've found is something called Prescription Kids, RX Kids. And it's where when you become pregnant, let's just say you pick an impoverished area, define the area, and so anyone in that area, a lady becomes pregnant, she gets $1,500, no questions asked. Once she has the child, she gets $500 a month for 12 months, period. So you're $7,500 into this investment into this child, a child that doesn't choose where they're born, a child that doesn't choose the family that they're born into. And so what it's done is decrease NICUs in areas where this program's been done, which is in Michigan, by 40%. Now, NICU stay is hundreds of thousands of dollars. We're spending $7,500 to reduce that by 40% pays for the program right there. And underweight children, that's decreased by 40%. I'm rounding these numbers, but it's significant numbers for healthy babies are born. And in the first year, and what we're looking at infant mortality is from a conception to year one. It's so important during that period. So, someone said, well, that's welfare. That's going to incentivize them to have more babies, or they'll go out and buy drugs with that. I think most mothers will take care of their child with that money. And it's not necessarily a government program. You're not looking at a lot of overhead, because you're just giving them money, and the results are outstanding. And
and there aren't strings attached on
there are no strings attached. You're not having
is the desire that they spend those monies on maternity care?
That's it. Or, it's interesting, the studies, and I'd love to show it to you one day. But a lot of their money, like, I don't know, 40. I keep coming back to 40%, but a lot of it was spent on rent. The mother just helping pay for where they live, because it's such a stressful time. If you look at when a family's having a child, there are a lot of expenses. There are a lot of vitamins and that they're supposed to be purchasing and buying and all to help prepare for this. But they're also limited in what they can do as far as a mother working, and they have doctor visits to pay for. So it's a financial burden to begin with. It's stressful to begin with. And so to help people in these areas with just a little extra cash ends up being a huge return on investment for that area and for the state of Mississippi. I've seen that. I know it seems far-fetched, but it's working.
It's a new idea. I hadn't thought of that, but I'm sure there would be unintended consequences that I would want to think through.
Absolutely.
But I like that you are thinking outside the box about how to solve these problems, and it's interesting. I've been reading a book called The Science of Second Chances by Dr. Jennifer Doliak, and it's about reforms in criminal justice. And one of the things she has been looking at, and she did, I don't think she conducted the studies, but she analyzed these studies that when people coming out of prison, they did a set of studies where they gave people cash on the way out the door. Now, I think in Mississippi we give $50 in a bus ticket or something, but they studied if you gave them $1,000 or $2,000. Again, there's all kinds of moral questions we would have to answer, and I'm not saying I'm promoting that idea.
I understand. We're just having a conversation.
Sure. But if you are purely looking at the math and the money we will spend taking care of them in the system if they commit another crime in their first 6 months and they're back in jail, and we're paying tens of thousands of dollars to house and care for them and food and lodging and medical care, versus giving them some cash on the day they walk out the prison, they found there was a huge benefit in improving recidivism rates on those that had cash than those who didn't. So I like the way you're thinking.
It's the same concept.
Yeah.
And the overhead, the administration of all that is simple, because here you got out of jail, here's your money. Now, and how you use it, there's no oversight, so you don't have all that administration, government red tape. It's a kind of a libertarian type way to look at things. If it's like welfare, if we didn't have all these thresholds, all right, if you're at this income level, here's the amount of money you get, and then see how people would rise out of that. Instead, we have all this red tape and all this that people are making a living off the government, when we could just and so there are studies that I've read about, but it's more of a libertarian type way of looking at things. But yeah,
well, the libertarians might argue handing cash to people isn't as libertarian, but I see what you're saying. It's not a big it's not a government agency.
Yeah.
So last question about that is, how would you protect, or where this has been considered, how would you protect against the unintended consequences of people having more babies out of wedlock simply because they get paid for it?
I don't know that answer. Yeah. I mean, I just don't think that's as prominent as people think. Kind of like your last guess, you said, how many bad actors are there really on social media?
Yeah.
I'm sitting there thinking 30% of the people out there are putting back, and he said it was 3%. And so I'm thinking there aren't going to be mothers. I'm going to try to get pregnant again so I can get that $7,500. I just maybe 3%.
Yeah.
But it's an idea. It's something that's working. It was actually where it started in Flint, Michigan, was authored by a Republican in their state legislature. This Dr. Mona Hanna has come up with a program. She's been to Mississippi. They've already picked 2 areas that they think. One would be Sunflower County.
Yeah.
And we've been we've been given the opportunity to get $2 million already for this program that would be a contribution from out of state if we just put up $100,000. So, I mean, it doesn't have to have legislation to do this. It is something that I'm studying. I will have return on real numbers, return on investments if we do this. And we can do this philanthropically if that's the need. And, we will take donations. And we did set up, not for Ari's kids, but, the health department and Ari, we passed a bill where they can receive donations for the Public Health Trust Fund. So, we make an earmark some money for that, and let's do a pilot in Sunflower County and see what happens. If it saves lives, if it saves lives, saves babies' lives, and I don't care what it looks like. Let's do it.
Well, I love that you're trying to tackle some of these big generational challenges in our state. And anyway, love your heart for people, love your heart for kids, and just respect the work you're doing at the Capitol.
Well, it means a lot to me coming from you, and I've always admired Empower. And you and I have had many conversations and about policy, and you've actually changed my mind on school choice over the years. So
love it.
Yeah.
Well, you've changed my mind on some things. So I appreciate you coming on. This has been a great conversation. Thank you for coming on the podcast.
Glad to do it. Thank you.
Thanks so much for listening to today's episode of the Empower Podcast. To learn more about how you can get involved and we can work together to make Mississippi a place where everyone can rise, go to our website at empowerms.org. Please like or subscribe on your favorite podcast app so you'll be notified of future episodes.